Good morning, everyone. Thank you so much for joining us today. We are going to be talking about the use of radiotherapy across the bladder cancer spectrum. I think that as more and more people are becoming more comfortable with bladder preservation for muscle-invasive bladder cancer, there's been a lot more investigation into the use of radiotherapy as part of the treatment paradigm in other places within bladder cancer. And I'm excited to get to introduce that to you and show you guys all the wonderful places that we can use bladder, either bladder-directed or metastasis-directed radiotherapy. And it's not just for like a T2N0 bladder cancer patient. And so I have a wonderful panel that is joining us. Two people are remote for sort of reasons that came up last minute. But we have Dr. Scott Delacroix, who's going to start us off talking about the use of bladder preservation or radiotherapy in the non-muscle invasive space. Scott, thank you.
So thank you very much for the invite. Always wanted to come to this meeting, but never gotten an invite till this year. So appreciate the invite. Can I get my slides up? There we go. Great. So I'm from Louisiana, from LSU. My tasks are threefold. Discuss the role of radiation in non-muscle invasive bladder cancer, really the potential role. You'll hear more about that from Dr. Bauman later on. And really give you just a sort of a general experience of my experience of trimodality therapy for muscle invasive bladder cancer. And really where I see, as a humble clinician amongst a bunch of scientists, where I see potential future directions are to try to improve outcomes in this disease and to try to stay on time. I already took a minute. So the role of radiation therapy in non-muscle invasive bladder cancer has some data, although it's limited. RTOG-0926 was a single-arm phase 2 study that accrued patients over an 8-year period. These were operable patients with T1 disease who were recommended to undergo cystectomy. Again, it was a single-arm phase 2. Patients received 7 weeks of radiation therapy with either cisplatin as a radiosensitizer or 5-FU and mitomycin. Number of patients accrued over 8 years was 37 patients. The primary endpoint was different than the primary endpoint, if you're familiar with 1806. The primary endpoint here was freedom from cystectomy. So it was not bladder intact event-free survival, which is a composite endpoint of recurrence, survival, and freedom from cystectomy. This was just freedom from cystectomy. The freedom from cystectomy on the data was 88%. But the overall survival, though, is when you drill down into it, again, on 37 patients. Overall survival at 3 years was 69% and 53% at 5 years. Large confidence intervals because we have small numbers of patients. The distant metastatic disease was 12% at 3 years and 20% at 5 years. So we look at other data that's out there on radiotherapy and non-muscle invasive bladder cancer, and this is data from Dr. Kusef at McGill, and he was looking at combining immunotherapy with radiation therapy. There's some data that suggests that radiotherapy can increase PD-L1, and he looked at timing of application of radiotherapy along with immunotherapy in a basic science model. He looked at it from a neoadjuvant, a concurrent arm, and an adjuvant arm. And interestingly, when you look at tumor growth in this study, controls, which received nothing, as you would expect, showed growth. PD-L1 and radiation both showed independent size reduction or reduced growth rates, but combination of radiation with PD-L1 had the best outcomes in this small study. And when they looked at the timing of immunotherapy, either concurrent, neoadjuvant, or adjuvant, it really didn't seem to matter. So I think that's sort of it's probably going to be an issue, or maybe an issue, depending upon the results of 1806 and subsequent trials as to whether or not concurrent is necessary, or are we getting our bang for the buck if we give it neoadjuvantly or just adjuvantly. In 2015, there was a clinical trials planning meeting, and out of this came 2 ideas for clinical trials. One of the trials was a platform-based trial that, as written in 2015, this is what it looked like. It had 20 arms. One of these arms had radiation in it. And the successor to this idea actually was just recently published, and this is the ADAPT Bladder study. This was published last month, and this was a phase 1 trial of durvalumab in combination with BCG, durvalumab alone, or with external beam radiation therapy. Again, these are small numbers. This is in non-muscle invasive bladder cancer. There's a delay on my clicker. Go back. There we go. And so this is BCG unresponsive patients. They could have been CIS or papillary, with or without CIS. And there were 3 cohorts: monotherapy IO, monotherapy or DARVO with BCG, or DARVO with external beam radiation therapy. And the radiation therapy was 6th grade, just in cycle 1 on days 1, 3, and 5. Mandatory biopsy at 6 months to assess for presence of CIS, regardless of what the cytology showed. When you look at the data, there was some differences between the cohorts, as you would expect in a small study, with CIS components and papillary components being a little bit different in each of the groups. But the CR rate was pretty impressive on cohort 2, which was DARVO plus BCG. Now, when you look at cohort 3, because we're talking about radiation therapy, cohort 3 did show a more impressive rate than IO alone. But the really interesting cohort was the DARVO plus BCG, and this was recently published. Actually, that was just a break. Let me go on. There we go. So, let's see where I am in time. See how much I've got plenty of time. So, I'm now going to jump over to trimodality therapy, sort of in the muscle invasive space. And evolution of my practice as really just a simple urologic oncologist who takes care of patients. I'm at LSU in Louisiana. Did my residency. Everything for bladder cancer was surgery, surgery, surgery. Fellowship at Anderson, it was neoadjuvant chemotherapy and surgery, surgery, surgery. Really, radiation was something that worked in Boston and in Europe, and it didn't really work anywhere else. So my first 8 years in practice just sort of did what I had learned. Neoadjuvant chemotherapy, surgery, incorporated robotics, and those kind of things. And then really got interested in, are there other options that truly are at play? And although I didn't have the knowledge to be able to step out into a trimodality therapy field on my own, the ability to do this on clinical trial has given me pseudo-expertise to be able to offer this to patients with some degree of confidence. And it's through these clinical trials that I have learned about this. And the 2 trials that sort of came to mind that we opened up were Go-Bayer's trial, and then within 6 months of that opening, the SWOG trial opened. This is where I've got the majority of our experience. And here's Goba's trial, which everyone in the room probably knows about and will be discussed. And here's Dr. Singh's trial, and he'll tell you about that, which has accrued amazingly well. And patients for this trial, despite what my initial biases were, patients in this trial are very happy to sign up for it. Initially, I was telling patients, look, Depending upon what data you look at, you may be sacrificing 10 or 12% survival rate by choosing to do TMT. Again, I had my surgical bias hat on. Patients are still willing to sign up for this trial. They are really highly motivated to try to spare their bladder. I wouldn't tell that to patients today after my experience treating about 75 patients so far on this. Let me go forward. This clicker has a delay. There we go. So one thing I've learned is maximal TUR is important. We utilize fiducials. And I'm not going to really get into the nuts and bolts of this. I can come back to this if we have questions. I'm not going to show you a video of a TUR and placing fiducials. It's simple. If somebody wants to learn, I can teach them after. This slide is really just to show a point that fiducials in the bladder does move around. So this is fiducials around a T2 site with the bladder full and bladder empty. Our radiation oncologist, my partners who are radiation oncologists, they really like that we place fiducials. I'm not a radiation oncologist, but they love it. So the further away the tumor is from the bladder neck, the more movement you'll get. And this is really what I wanted to talk about. Optimizing bladder cancer outcomes beyond bladder preservation. You're sitting here in a bladder preservation work group. We're talking about optimizing bladder preservation, but where I think the field and the trials need to go is optimizing bladder cancer outcomes, not just looking at the bladder. My general impression, and the data suggests, and doesn't suggest, it shows that we can do a good job of sparing patients' bladder and preventing muscle-invasive recurrences in the bladder. The problem is with distant failures. That's not a problem with the trimodality therapy locally. It's potentially a problem that our systemic therapy agent that we're combining with our local therapy is not equivalent to what we're doing on the surgical side. So on the surgical side of patients coming in, they're getting 4 cycles of dose-dense MVAC. We're marinating them like a pickle. And then we're taking out their bladder. And then if they still have unfavorable disease post-neoadjuvant chemo, we're then offering them adjuvant therapy. In the trimodality therapy space, we're behind the time. Can you keep my slides up? We're behind the times. Mainly it's because of the lack of adoption of trimodality therapy. So there's no adjuvant studies in this space. So we're falling behind on distant failures, where on the surgical side of things, we're treating more aggressively systemically. Should we give neoadjuvant chemotherapy prior to concurrent TMT? The data's all over the place, depending upon what you read. A recent trial just came out that says, yeah, there's a benefit. You look at the data out from Dr. Kusef in European Urology. But there are 2 or 3 other papers that say, no, it doesn't make a difference. There's lack of adjuvant data here. These patients, if we treat TMT like surgery, why aren't we doing adjuvant trials in this space? Sort of are with 1806. And then systemic treatment intensification. If we're going to go down this road, how do we do this smartly? Clinical staging sucks. It's not great. Okay? You can use MRI. My TUR may be better than the 75-year-old urologist. Our staging is not great. Can we do this more smartly? Can we do this with circulating tumor cells? Can we do a Signatera? Determine who needs neoadjuvant chemotherapy or who post-trimodality therapy needs adjuvant therapy? How do we make smart trials to go beyond just caring about the bladder, but the systemic recurrences that occur? And then obviously focusing on the bladder, if I go beyond the distant recurrences, 7 weeks of radiation therapy is a lot. And patients need to travel for this. Is there a role for hypofractionation? Is there a role, I know there's data out there on 20 fractions. Is there a role for ultra hyperfractionation in this space? We don't know, but it's an opportunity for a trial. Nodal treatment, also very variable data that's out there on whether or not there's a benefit versus no benefit in treatment of the nodes at the time of trimodality therapy. And can we use novel systemic agents in combinations along with radiation therapy to not only help preserve the bladder, but to help preserve distant recurrences? That's an opportunity potentially for clinical trials. And I'll leave it at that. This is us last week. And I had 30 slides, but I think I got through it in 15 minutes. So thank you all very much. I appreciate it.
Thanks so much, Scott. For our people on Zoom, they can't hear us unless we use one of the two microphones. So when we get to the sort of question and answer, we'll pass around the microphone. Next, I'd like to introduce Dr. Parminder Singh from Mayo Clinic, who's going to talk to us about his current trial, SWOG NRG 1806, as well as sort of the role of radiotherapy and bladder preservation for muscle-invasive bladder cancer. Thank you.
Thank you everyone for joining in today. Appreciate Tom being here and all the group coming in. It's always a pleasure to hold a forum with Leslie, my partner in crime in radiation. So thanks for putting me on the panel for this session. My task today is to talk about S1806, which you all know is intact trial, and what's coming next, or next steps in that direction, something which will line up nicely with Scott's presentation. So we'll move on to some disclosures. Can we have my slides on the Zoom, please? Thank you. I have some advisory roles with AVO and Seattle Genetics and Janssen. Some of them are compensated and some are not. So we'll move to the first key slide is 1806, which I'm just going to spend 2 minutes here just to kind of remind people what we have been studying in 1806 and how it came about. This idea started in 2016. As we were discussing enrollments on 1605, which was looking at atezolizumab in non-muscle invasive bladder cancer, and we were asked to think about other bladder preservation ideas, which was in line with preserving bladder and non-muscle, because those patients were going for radical cystectomy for BCG unresponsive disease. But then in the same vein, we figured that we can progress this idea into muscle invasive bladder cancer by adding maybe to chemoradiation and think of bladder preservation in muscle invasive bladder cancer. So this trial was actually a subsequent trial to 1605 in the space of preserving bladder for bladder cancer. Actually, I'm not moving this. So let's see. So this trial we designed as a large phase 3, which was, at that time, it was anticipated that this trial will have a lot of hurdles to enroll in US, because traditionally, as Scott pointed out too, most of the urologists are trained in looking at directions towards removing the bladder. And we anticipated that having a large trial in US will be a tough. There was a lot of criticism and also objections presented in various committees that we'll be spending so much money and effort and this trial will not accrue, which was good because we started thinking how to design this trial pragmatically so that we can accrue on this trial. And now I think it is a kind of a test. S1806 would be more of a model for how to design a pragmatic study in bladder cancer, because I'll show you how very well it accrued in US, which was again, we were not expecting that. And the first thing we did was to kind of design the trial in a way that it kind of aligns with what the kind of patients we see. And we brought all the cooperative groups together in the design phase as we started to build this trial. So this trial was looking at patients who had muscle invasive bladder cancer, which was not N0, M0, just T2, T4. They'll be randomized and stratified based on the chemotherapy regimen, radiation field, performance status, and clinical stage to receive chemoradiation or chemoradiation with atezolizumab for a duration of 6 months. Why 6 months? Because we thought that we want to design a trial which is looking at a question about definitive therapy to bladder cancer. We did not want to purposely address a question of neoadjuvant or adjuvant therapy, because we felt that that would muddy the concept, and we will try to achieve so much in a space where we are anticipating the accrual will be difficult. So we decided we'll focus on one question, which is to improve the definitive therapy. So then if we are looking at definitive therapy, then the outcome or the primary endpoint should align with the intent of the trial, which was bladder intact event-free survival and not OS. We had to build this new novel endpoint for a phase 3 registration trial and get it approved by FDA as an endpoint because it aligns with the spirit of the trial, which is a patient has the bladder, and if they lose the bladder for toxicity, then they should meet the endpoint even if they are alive, because now they have lost the bladder. So BIEFS is a novel endpoint which includes losing a bladder even if you don't have a cancer. So then you hit that point. In addition to the survival endpoint. So dying from any event leading to death would be part of BIEFS, and also losing a bladder for any event will be part of BIEFS. So, and in addition to all the other primary, secondary endpoints. I won't spend much time on rationale because now we understand why we combine immunotherapy with CRT, because there is, as Scott showed, that there is increased expression PD-L1. There was data coming from other cancers which was showing that durvalumab was getting approved in lung cancer space at that time with chemoradiation. So we figured that it is kind of, we are at the right time where it is time to add immunotherapy. And there were already phase 2 trials which were going on in that space. So we were able to convince FDA and CTEP to allow us to do a phase 3 without a phase 2, because we'll have a run-in of 80 patients for safety, and then that will then go on to become a phase 3. So this is the success of 1806. We didn't anticipate that we'll accrue so well, but as Scott pointed out, people wanted it. Patients wanted it, and that's where engaging with our patient advocates, Rick is here, he was instrumental in moving this trial forward through all the hurdles which we were anticipating, and kind of advertising this to this point where we now have actually met our accrual in terms of the 432. Now we are just enrolling patients for the 10% ineligibility, because we expect there will be 10% patients which will be ineligible. So we are accounting for that, and we'll be accruing up to 475 hopefully by end of the year. And the lessons we learned through this process, which kind of a study for us, is that we align the eligibility as patients we see in the clinic. We figured that patients are going through one clinic to the other, from a community urologist to the academic center, then to the radiation oncologist, to the medical oncologist. We kind of left the eligibility windows wide for 70 days and 120 days for their TURBT. We saw that we see patients with mixed histology, and we left the word mixed histology, and we did not specify any percentages, 50% of urothelial or 25% of squamous, nothing. As long as you have urothelial in your bladder, you are good for the trial. And so we thought through the language of eligibility to make it very simple and should not have any double meanings. But still, there were pitfalls which we learned through the process. Next slide. Sorry, one slide back. And then we kept the standard of care as standard of care. We allowed any chemotherapy which a physician would like to use, but we figured there are 3 regimens, and we were able to stratify based on those regimens within the design. We allowed dose modifications as you would do in the clinic. We allowed response evaluations as in the clinic. And there were flexibility on antiemetic regimens. We allowed the follow-up schedule to mirror what you would do in the clinic for these patients. And then we learned some lessons too. Despite thinking through all this, there were still some pitfalls. We figured that we realized a lot of people use PET scans in the clinic for staging, and we had kept PET scans out. Maybe we will allow them next time. We had a very tight somehow window for an EKG. TB history language was messed up. And then people want to use hypofractionation. As Scott pointed out, 6 weeks, 7 weeks is too long for patients. And now more and more community centers are using hypofractionation. I get calls all the time. In fact, even my own patient at Mayo Clinic at Rochester, one of the new radiation oncologists, he didn't realize, and he treated the patient on hypofractionation schedule even though the patient was on a trial, because we use hypofractionation in Mayo Clinic. So there was a deviation. But that's something which we need to consider in our next designs. And also incorporating some health economic components early on. We got late in adding those designs, and we kind of lost the window to put it into the trial. So what will S1806 lead to? So let's imagine that it is a victory, and we end up winning this trial, and it's a positive trial. The trial is designed to look at 12% improvement of BIDFS at 3 years, which is going from 52 to 64%. So I'm not sure if that is still a home run, but it is improvement, but there is still a lot of room for improvement. And that's where we are now focusing our efforts in designing the next trial, which is going to come after 1806. And so I went back to the drawing board. I reached out to Rick, and that's what we did before 1806. I asked him, what are the 3 things in your mind when you are going through bladder preservation from a patient's point of view? And he said, cancer, bladder, and cost. And in cancer, will the treatment truly eliminate my cancer? And for how long? And what happens if the cancer returns, as Scott pointed out, to metastases? Will my bladder be worth saving the time of treatment and then beyond? And what's the cost I have added on for bladder preservation? So those were 3 things in his mind. So I kind of started focusing on the metastases component to his the points that he presented. And next slide. So looking back to MGH data, and we see that close to 32% of patients will have distant metastases after successful CRT. So we're just focusing on distant metastases. And so it kind of lines with other trials which have been presented in this space. So this is the BA06 trial looking at CMV chemotherapy before definitive radiation or radical cystectomy. This was a European study. And it showed that doing chemotherapy in the overall population improves the outcome by 6%. Not so much if you tease out the radiation, patients treated with radiation, but more so in the cystectomy. But since they had the data for the overall population, we see improvement in 6%. So I'm going to point 2 things to you. So one, neoadjuvant chemotherapy prior to radiation it is not offering more than 6%, and that's a platinum-based chemotherapy. And so still there are so many patients who are recurring and having distant metastases. So just keep that factor in mind. So, and if you look at platinum-based chemotherapy before other definitive therapy, which is radical cystectomy, the improvement is close to 12%, and that too with p-value of 0.06. So even if we use a good platinum-based regimen, the improvement is going from 6 to 12% prior to definitive therapy. So just kind of repeating that point. And then there are trials in radiation which has shown that neoadjuvant chemotherapy before radiation may not be improving benefits. This is the only phase 3 randomized study, even though it didn't accrue, but it failed to show any improvement prior to definitive CRT. And then if we look at data in patients from, again, UK group, these are patients who had lymph node metastatic disease, and they received chemotherapy, neoadjuvant chemotherapy, to shrink their tumor, and then receive radiation. You still have 30% of patients with distant metastatic failures. So despite getting platinum-based chemotherapy, patients are still failing. And so what can we do to improve this systemic recurrence? And I feel that we have enough data from various radiation trials from RTOG, MGH data, Canadian data, and they have tried to place chemotherapy in between. So there was RTOG 0712, which has like in between chemotherapy or after, they have done chemotherapy after initial boost of radiation, but there has never been a significant improvement beyond this 10-15%. So we need to look beyond. I think the era for platinum is coming to end in this. And what are the possible solutions? Is there a better drug? Is there a better combination? Is there a better timing to give this therapy, or better selection of high-risk patients, as Scott said? So what is the right recipe here? We need to figure that out. So I'm looking for solutions for the next step, So then I put together all the data for various combinations of therapies we have right now. So we have Keynote 361, we have GC versus MVAC, we have atezo chemo plus chemo, we have EV Pembro versus EV, we have SG Pembro. So if you look across in the response rate, there is a significant jump in response rate where you are combining ADCCs with immunotherapy. We see in first line setting 65 Terry is here, and it's his data looking at such high response rates with EV Pembro. And then in second line setting, SG and Pembro is having close to 40% response. So there is something to these newer ADCCs when combined with IO where we are seeing this significant jump in response rate. And I think that's the combination we need to now capture in the CRT space to improve our distant metastatic risk. And so next slide. Sorry, went too fast. Okay, so one is that combination, and the second is the selection of the patient. And so how can we select the patient who should get this intensification with a new combination is maybe we identify these patients using ctDNA. There's data to now show, which I've not had the slide, but you all know that ctDNA being positive kind of is a good prognostic marker for future recurrences. And then can we use the same, this is for radical cystectomy, so can we use the same data for TMT? Maybe we identify that group of patients who is positive post-definitive chemo-RT and then add intensification. And from 1806, internally, I'm allowed to speak about this, is that we are looking at high-risk features in patients who are getting enrolled on 1806, and how are they behaving. And so we will have that data, and our assumptions are that these patients will behave as high risk for recurrence post-definitive therapy, and maybe we can use these factors to then enrich a population of patients who needs the intensification. And so then using a newer combination, which is far better or more active in bladder, and identifying a higher risk population, we should be able to then propose a new trial design. Sorry, next slide. This one. So this is a new trial design which now SWOG is working on, will be to identify these patients, so patients who had T2, T4, and they received chemotherapy, standard of care TMT, which could be based off 1806 or whatever the standard would be at that time when this trial comes up. And we will identify the high-risk patients, and we will then randomize them to receive an ADCC with pembrolizumab for 4 cycles versus observation, which would be the standard of care, and then look at the similar endpoints, maybe BIEFS, or maybe we'll have metastasis-free survival as our primary endpoint. So this is something, a flavor of what is coming in this space, and that's where I'll end. Thank you.
Thank you so much. I think in the interest of time, we're going to go on to Dr. Monika Joshi's talk on radiotherapy for node-positive bladder cancer, and she is on Zoom, and then we'll do a whole bunch of discussion afterwards.
Thank you, everyone. I'm sorry couldn't be in person. So my goal here is to kind of bridge the very interesting talks from Scott as well as Parminder. Sorry, my voice is a bit scratchy. So I'm going to talk about node-positive bladder cancer and hopefully pass the buck to Brian to talk about the role of radiation beyond muscle-invasive disease. So these are my disclosures. I hope to touch upon a little bit about introduction to node-positive non-metastatic bladder cancer, because this is such a new space. And then we'll talk about E8185, which is the cooperative group study focusing node-positive non-metastatic patients. And then I wanted to share a patient experience and hopefully bridge and make the talk interesting, so you all can think and suggest what the next steps should be. So to this group, I don't need to kind of define what lymph node staging for bladder cancer is, but what I want to kind of emphasize is how new this space is. It only started sometime in 2017 when it was reclassified. And it's important to remember because I think this is an entirely new area as opposed to muscle invasive space that has been looked into, node negative muscle invasive space that has been looked into for chemo-RT or bladder preservation for decades. And we're so glad that we have Parminder's study moving forward and hopefully giving us new standard of care in future. What we really should also think about is how do we define a lymph node? More and more we've been doing studies, and just boxing ourselves into the RECIST criteria is perhaps not very smart and not very feasible for bladder cancer patients. What we also think is reality is different. Being a perfectionist, we want biopsy to prove it's positive, but when we're sitting in clinic, perhaps it's not possible because the node is somewhere that it's not approachable, or perhaps the patient doesn't want it, right? So there's several factors that play a role into why biopsying all node is not going to be possible. So we really need something better imaging, better modality to pick these patients. And that's what we should also be thinking as our next step in our next study. IMPART results, I think you saw Parminder present that. I'm going to just twist it a little bit. This actually established the feasibility of chemo-RT node positive. You can again see small sample size. So this is not a very common population to have. More and more we're doing studies, we are realizing that node positive group is perhaps less common than what we thought, and maybe because we just don't have modality to pick it up. But what's important to note is there was no difference between N0 versus N1. So again, these patients do well, and it was feasible to deliver definitive radiation therapy. This was our study, the Big Ten, concurrent durvalumab and radiation therapy, followed by adjuvant durvalumab. These were patients who were locally advanced, not eligible for cisplatin. We actually have published the results in Journal of Immunotherapy for cancer, and then you can look at it. It has not just clinical, but a lot of data for even correlative, and lots that we have not published that we are still wrapping our head around. What Duarte did show, this was concurrent durvalumab and radiation followed by adjuvant. So this was one of the initial studies that looked into adjuvant immunotherapy for a year. And we focus, just for this talk, what we do realize that node positive patients had similar median PFS and OS when compared to the node negative. And 1 year overall PFS was 71.5%, whereas the overall survival was 83.8% for the total population. We also picked up some that patients who had high tumor mutation burden, more than 10, did better than those who didn't. This was a very recent paper that you all must have read, published in JCO, retrospective analysis coming from United Kingdom. 2012 to 2021, 287 patients, node positive, non-metastatic. They were focusing into patients who received radical treatment, whether radiation, definitive radiation with or without a chemosensitive agent, or receiving palliative. And the numbers are shown here. The outcome was better for patients who received radical treatment when compared to receiving palliative treatment. What was also interesting was the choice of radical treatment, whether you actually opt for surgery or radiation therapy, showed no difference in OS. So again, this is something that we can actually offer to patients and perhaps spare them with some of the side effects from the surgery. This is our E8185. So again, it's a phase 2 study of bladder-sparing chemoradiation with durvalumab in clinical stage 3 node positive. As best I can tell you, this is the only prospective study. All of the data that is currently present mostly is retrospective, or they've formed a small cohort in other prospective studies, but not the majority. So when we were designing this study, we actually designed very similar to the study I showed you, the retrospective one. But because we were learning more about this space, I think when it went through task force and GU steering committee and various cooperative groups, I think we wanted to make it really neat and clean. And we later realized perhaps that wasn't the best way to do it. We have to keep it simple. So we made a lot of changes. So it's any N1 to N3 and node could be biopsy positive, radiologically suspicious. We've kind of kept the room open. We've also removed the requirement for neoadjuvant chemotherapy. While you heard a lot from Parminder, it's still questionable, but it wasn't really favored by the patients. They didn't want to wait that long before they get the definitive treatment. So we removed that option. And the patients would be divided, randomized to chemo-RT plus or minus durvalumab, and those who would receive response would go on in the experimental arm to adjuvant durvalumab. So primary endpoint is complete response. So again, the study is open. We want to kind of enroll in it because if this doesn't work, then what's next? I think, again, it's a new space, so more ideas should come into how to push this study. We have improved the design. We looked into, had various meetings, and then we realized it's a much rarer clinical scenario, and that unfortunately has not changed. We have relaxed the mandate for the neoadjuvant chemotherapy. We have simplified the node positive definition. Impact due to COVID, as I'm speaking, I am myself positive. So, but the fact that you guys are all sitting there says it is probably improving. And a study is open through all the cooperative groups. And again, simple is better. That's what we've learned. So we'll keep that in mind. I wanted to share lastly a patient experience. This was a patient in 2017 when the stage was coming out. We had the DeWart open. She was very interested in going, and we realized initially she was thought to be T1, and when she went for surgery, they found some nodules. There was suspicion for local spread, but on hindsight, perhaps she was T4 node positive only, and she got her treatment. I'm going to let her speak and tell you the story to see how patients feel about this approach.
So, Beverly, could you share with us? Certainly. I came to Hershey in 2017, and I had third stage bladder cancer. It was determined that I wasn't able to have my bladder removed. However, I did have to have nephrostomy tubes in both of my kidneys in order to take the urine out. So I had bags on either side of my legs. After that, I was given the options of chemotherapy, radiation, and immunotherapy. And I can tell you, I was so pleased. I was so pleased. So I first had chemo, and I had tiredness, sometimes extreme tiredness. I had loss of appetite. I didn't have nausea because when I got my chemo treatments, they always gave me nausea medication. I did end up with neuropathy in my feet, but I found that exercising really helps with the flexibility of my feet and my balance. So then I was on to radiation, which 33 treatments, they took 5 to 7 minutes. My husband would just drop me off, go to the parking lot and wait. And I had no effects. from that. And then it was to immunotherapy. Immunotherapy, I had several treatments. I didn't do quite as well. I had some diarrhea, some like blood value issues. And then 18 months passed and I had my nephrostomy tubes taken out. And my doctor put stents in my ureters, which the ureters go from the kidneys to the bladder, and mine had been crushed. So he put the stents in, and I had this full functioning bladder. It was like a miracle. Like I couldn't believe it. And I go every 6 months or a year for follow-ups. I just started 5 years in remission. I am so, so grateful to God and to my doctors for where I am today. I feel so healthy. I feel like I have never really been sick, which is just amazing because it was a journey. But one thing I will say, my doctors always listened to me. They always listened to me. I could come up with some of the strangest questions. And
So that was, I had to cut it short. I think she spoke a lot about our center and Dr. Keg and myself, and I wanted to spare that to you guys. But I think the bottom line is that you could hear how much this combination, the chemo-RT and immunotherapy, I do believe that immunotherapy did give her a good response. So with that, I think, with that, we'll go up to the summary. So multimodality treatment with bladder preservation and node-positive non-metastatic bladder cancer is feasible. And I do think that it needs to be evaluated in prospective trials. Perhaps we need to have a single arm. Perhaps we need to have additional arms with different combinations that could show. With that, I think I'll end, and I'm going to pass it over to Dr. Brian Bauman, who would be giving the next talk. He's already very well-known radiation oncologist from Springfield Clinic. He's also the co-chair for the NCI Bladder Cancer Task Force. So Brian, I'm going to stop sharing, and you can share yours. Thank you.
Okay, great. Well, thank you, Monika. Thank you to the team. Again, I'm also sorry I can't present in person. I'll be sharing my slides here. Just a sec. Okay, so I'll be talking about radiation therapy for local recurrence and for oligometastatic bladder cancer. These are my disclosures. So here's an outline of the talk. So first we'll discuss local recurrence, and then we'll discuss oligometastatic disease, and those are the key points I want to hit for each topic. So to start off, I think the best way to treat a local recurrence is to prevent one from happening in the first place. And so I'll briefly review the role for adjuvant radiation. So the rationale to do adjuvant radiation after cystectomy for patients with locally advanced disease is really the high rates of local failure that have been reported in modern series for patients with T3 and T4 disease and or node-positive disease, with rates at 5 years between 20 and 41%. And I think importantly in this disease space, chemotherapy has been shown not to reduce the risk of local failures. Neoadjuvant chemo didn't do it in the SWOG 8710 or in the URTC MRC trials. And it's unclear if adjuvant immunotherapy has an impact on local failure based on the published data from the trials. Once these failures happen, they're very rarely salvageable, and they're associated with very poor median survival of 9 months. And compared to some of the older data looking at adjuvant radiation, modern technique, IMRT, is actually very well tolerated in prospective series with excellent local control. So these are just some of the, in my opinion, key studies that have reported on adjuvant radiotherapy. I think arguably the most important one is the one at the top, which was a randomized phase 2 trial conducted in Egypt. Patients had to have negative margins, locally advanced disease. It was 120 patients, and they were randomized to adjuvant kind of sandwich chemo, followed by adjuvant radiation, followed by 2 more cycles of chemo versus just 4 cycles of chemo. And the trial was a positive trial. So the primary endpoint was local regional control at 2 years, and radiation, the addition of radiation improved that 96% versus 69%, with, again, kind of trends toward improvement and disease-free survival as well, but the trial wasn't powered for that endpoint. From kind of the same parent trial, there was a comparison of adjuvant radiation alone versus adjuvant chemo alone. Again, also with GEM-CIS ×4, and adjuvant radiation was found to be comparable to adjuvant chemo for patients with respect to disease-free survival. So in patients who may not be candidates for adjuvant systemic therapy, radiation, at least in this trial, appeared to achieve comparable outcomes. And this is a trial with majority urothelial patients, and on subgroup analysis looking at only the urothelial, all of these results held. There's some retrospective data from the National Cancer Database that our team did that showed an association with improved overall survival for getting adjuvant radiation. And then Valerie Fontaine's important, very recently published trial using modern IMRT. It was single arm, but it showed that acute grade 3 GI toxicity, which had always been the concern, is very low, only 6%. And so NCCN guidelines have said that you consider adjuvant radiation for patients with locally advanced disease, node positive, positive margin. I think there's an especially strong argument to use adjuvant radiation for squamous cell, and this is prospective data to back that up. So this was an unplanned subgroup analysis from the Egyptian trial, 77 patients with pure squamous cell, and looking at the 3 different adjuvant therapies, adjuvant chemo alone, adjuvant radiation alone, or adjuvant chemo and radiation. Giving adjuvant radiation actually improved overall survival versus chemo, and that adding chemo to radiation didn't change the outcomes versus radiation alone. And the sort of survival curves there are quite stark, 2-year overall survival, 71 versus 43. So I think there is an argument to be made for doing adjuvant radiation for squamous cell, where systemic therapy so far appears to be less effective. So if we're going to treat patients adjuvantly, which sites should we treat? Well, I think it's really important to identify the patterns of failure if you're going to attempt to do that. So this was research that we did some time ago when I was at Penn, where we mapped the sites of failure in over 400 patients. And you can see that the failures really concentrated in the pelvic lymph nodes, with fewer failures in the cystectomy bed in the presacral region. And this kind of led to the development of a consensus contouring atlas through the NRG, where we defined the cystectomy bed and how to contour it for the first time in a more rigorous way. But the consensus at that time in 2016 was that you could probably omit the cystectomy bed for margin-negative patients, because the existing data at that time showed very low rates of cystectomy bed failures for R0 surgery. Now, fast forward to more recently, some new data has come out, and there's now a new consensus contouring atlas led by Valerie Fontaine. And this shows really that the recommendations have changed, and I agree with these new recommendations to include the cystectomy bed for T3, T4 patients, regardless of their margin status. And the new data that's come to light is data from Dr. Zagul's Egyptian trials, showing that excellent local control, 96% at 2 years, and a very favorable side effect profile when you include the cystectomy bed for margin-negative patients, because all of the patients in Dr. Zagul's trial were margin-negative as a requirement. In addition, from Dr. Murdy and others, there's been some more patterns of failure studies that are actually suggesting cystectomy bed failures are more common. Now, I think that with modern IMRT, and Dr. Ballas knows this from some research that she's done on this topic, we can really spare a lot of the bowel and urinary diversion to really a terrific degree. So the red here, indicates the high dose region, and the green is sort of medium to low dose. So you can see we're treating our target with a lot of sparing. And in the case of the urinary diversion, with our physics and dosimetrists, we're able to really carve that out and protect it. So the urinary diversion is getting less than 5 gray, which is really, a clinically not meaningful dose of radiation. And it's very important, of course, that we keep the dose to the urinary diversion low to minimize the risk of side effects. So I'm going to shift gears a little bit, talk about salvage radiation once those local recurrences happen. So the first kind of topic is, how do you handle local recurrences, after primary radiation to the bladder? Well, if the patient recurs in the bladder, I think there's really little to no role for salvage reirradiation for those patients, and surgery, if it's an option, would be preferred. The situation is a little different if the patients recur in the nodes after primary bladder radiation. And I think as long as the sites of failure are outside of the prior high-dose treatment fields, it's reasonable to consider another round of radiation directed to those nodes. There's no clear right answer as to whether you should treat those nodes with SBRT or do elective nodal IMRT, treating all of the pelvic nodes and then boosting the involved nodes. There is some data that we can perhaps extrapolate from prostate cancer, but that in itself is also retrospective, that basically found lower rates of nodal failure if you took a more elective nodal approach of treating all the nodes and boosting the involved ones as opposed to only treating gross disease. Now, what about in the situation for recurrences after cystectomy? So this can be challenging because there's a lot more small bowel in the pelvis once the bladder is removed, and this can limit dose escalation. And the fundamental problem is that gross disease typically needs about 60 plus gray, whereas small bowel tolerance taps out at around 54. So how do we make up the 6 gray difference? Well, if the disease is really close to bowel, the answer is, you often can't. In this situation for pelvic nodal recurrences, I still favor treating the pelvic nodes comprehensively, which has been our approach in prostate cancer, and then boosting the involved nodes to a higher dose. And I think it's debatable whether or not you should include the cystectomy bed in those nodal volumes at the same time. But I think if you're able to get away with it going above 60 gray, it will certainly improve your chances for local control. And I think SBRT is also an option in this situation. So this is the case of a patient that I treated recently with locally advanced bladder cancer. They underwent a cystectomy. They received neoadjuvant chemo prior to the cystectomy, and they developed really a very advanced left obturator nodal recurrence that extended into the surrounding bone. And so we did SBRT to this lesion, and we were able to treat the tumor to 35 gray, which is, close to or really, arguably an ablative dose, with, the adjacent bowel, getting only 20 gray, which, bowel can handle a lot more than that. So this, again, shows how good some of the technology is getting to allow us to treat targets that we couldn't really treat with such definitive doses in the past. So now I'll shift gears again into the oligometastatic disease space, and the first topic is metastasis-directed therapy. So I think everyone in this room is likely familiar with this trial, Saber Comet. It was a relatively small trial, 99 patients, randomized phase 2, trial of best systemic therapy plus or minus SBRT to all sites of metastatic disease in patients with recurrent oligometastatic disease from solid malignancies. And the 5-year overall survival was considerably better in the arm receiving SBRT, 42% versus 17%. And, that was associated with a 13-month improvement in median overall survival. And the survival curves are there on that side. Now, importantly, there's no subgroup analysis of the urothelial patients who were enrolled on this study. They were eligible to be enrolled, but they were sort of grouped into the other category. But this certainly has gotten a lot of people excited about the potential role for SBRT in metastatic bladder cancer. I think the role for it is not really well defined, but there are some retrospective studies that I think show potential benefit doing either surgery or SBRT. One of them is this older study from Lehman from 2009, where the 5-year overall survival was really quite good, 28%. This is in the era before immunotherapy. Of course, with the possibility of combining radiation with immunotherapy, there's thought about potential synergistic effects. And again, some smaller retrospective studies that are at least pointing toward potential benefit here. So this was a study of 22 patients who were treated to all sites of disease after receiving chemotherapy with at least a PR. And most of these patients had regional nodal disease, but there were patients with distant nodal, some lung mets, and then some other disease. And basically what they found is, compared to historical controls, that 36% of these patients were disease-free at 6 years. So not proof by any means, but certainly some additional kind of corroborating retrospective data that there may be some value in this approach. This is a larger retrospective series looking at patients with who were treated with SBRT. The other trial wasn't, strictly speaking, SBRT for urothelial cancer. And you can see that local control was excellent, and that's the survival curves there. Progression-free survival, again, I think reasonable compared to historical controls, but you can see that progression-free survival was much better in the cohort that only had one site of metastatic disease as opposed to 2 or more. So similar to what's been seen in other histologies, we can achieve really good local control, but the question is, does that matter if we can't control progression in other sites? And certainly lower volume metastatic patients seem to do better with this approach. So I want to just focus briefly on, I think, a special case within recurrent oligometastatic setting, and that's M1 disease, and in particular those most favorable of M1A patients who have just periaortic nodal recurrences. My general approach here, and again, this is really in the absence of any good data, is if they have sort of lower periaortic recurrences below the renal vein, I'll treat the pelvic in the lower periaortic region to about 50 gray and then boost the involved nodes. For the patients with, high PA recurrences, I tend to treat those more like a distant met using SBRT to, about 35 gray 5. And I'll often consider simultaneously treating the surrounding uninvolved PA region to a dose high enough to adequately treat microscopic disease. Now, what about kidney toxicity with this approach, especially if we're treating PA nodes that are nestled between the kidneys? Well, again, I'm routinely amazed at the excellent plans that they're able to generate for us. And we're able to achieve mean kidney doses that are routinely less than 5 gray. So again, a clinically insignificant dose of radiation to the kidneys that we couldn't have achieved 10 years ago, maybe not even 5 years ago. So the last topic here is radiation at the primary in patients with metastatic disease. And I think a lot of the interest for this is coming out of the STAMPEDE trial in prostate cancer. But really, there's no prospective data, to my knowledge, for doing this for bladder cancer for oligometastatic disease. There's some retrospective studies that suggest a potential benefit, but there's major selection bias and potential confounding here. So the SISON study from a number of years ago looked at cystectomy or radiation and found that using National Cancer Database that there was an association with better overall survival, but there were very few radiation patients included, only 49. So we sort of repeated that analysis, only looking at patients treated with combined chemotherapy and radiation, and had a much larger cohort of patients, almost 700 total. And we found that there was an improvement with an association with better overall survival for the patients who got chemo-RT versus chemo alone. And this benefit persisted on propensity matched analysis and on landmark analysis. And again, the magnitude of the effect kind of remained doing other sensitivity analyses to try to account for selection bias and unmeasured confounders. The median overall survival difference was, almost 14 months versus 8.5 months. So in terms of the rationale for trial in this space, well, I think there's some retrospective data showing potential benefit, but really selection bias could be driving that effect. And importantly, the burden of metastatic disease is not reported in the NCBB. I think the current data is more hypothesis generating, and it really needs to be evaluated in the trial. And the success of SWOG 1802, asking this question on the prostate cancer role, I think shows that the topic is of great interest to our community. And I think that such a trial should probably include both cystectomy and radiation, similar to the design of SWOG 1802. So, in conclusion, on the topic of radiation for local recurrence, adjuvant radiation, has been shown in prospective studies to significantly reduce the risk of local failures for patients with locally advanced disease at the time of their surgery. And this appears to be regardless of systemic therapy. I think for patients who have recurred, successful salvage requires a higher dose of radiation to control gross disease than what we need to do in the adjuvant setting. And there, bowel toxicity becomes a greater concern. So this is not the same situation as prostate, where salvage radiation is arguably just as good and potentially better even than adjuvant. Salvage is much less likely to be successful in bladder cancer. With respect to oligometastatic disease, the data for radiation is limited. It's really just hypothesis generating. And I think this is a fertile area for future trials. So thank you all for your time.
Thank you so much, Brian. So I'd like to first have Scott and Parminder maybe come sit up here and open up the discussion to questions from the group and just discussion points. If you ask your question, I'll just repeat it into the microphone so we don't have to be running back and forth with the one and only mic. Kent.
Hey guys, great talk. Maybe a little bit of a specific question for Brian and Liz and the other rounds. In the adjuvant radiation space, how are people sequencing radiation with adjuvant needle, given that the risk factors kind of overlap? I'm interested just to see what people are actually doing.
So if I heard the question, it was adjuvant chemo. Was that the question?
Adjuvant Nevo, so
Oh,
IO.
Yeah, I think great question. Again, no clear right answers here. I mean, in general, my kind of the approach that we were taking at WashU when I was there was, for patients where we felt like the risk was greater for distant relapse. So the patients, had positive nodes, that, the priority would be systemic therapy. For patients who were, say, T4 node negative, and especially if they were positive margin patients, would usually start the radiation first and then, be giving the immunotherapy concurrently, or start the radiation and give the immunotherapy, afterwards. Parminder's presented some very encouraging preliminary data on the SWOG NRG bladder trial that, concurrent chemo-RT plus atezo, again, in a slightly different disease setting, TAC bladder setting, is very well tolerated. And our limited experience doing combined Nevo and radiation, or combined Pembro and radiation in some cases, has been also quite good. With IMRT, I think it really helps. I think that, arguably the immunotherapy for most patients probably should be started first, and that, you can see how well they're tolerating that from a GI perspective before adding in another potentially GI toxic treatment. But I think these are questions that need to be answered. We don't really know the role of adjuvant radiation in combination with adjuvant immunotherapy. I think it's a great trial concept.
I just want to sort of second the point that Brian brought up about the toxicity data from SWOG NRG 1806. What's been presented thus far is that there's no additional toxicity when you combine the two treatments to, sort of the immunotherapy alone, and it is very well tolerated. And so I've been willing to overlap the treatments, especially since in the adjuvant setting, you're commonly going to a lower dose anyway if you're respecting bowel tolerance. So I haven't, sort of avoided an overlap.
Who else has a question? I'll bring you the mic. That way, we don't have to repeat. It's a small group.
Hi, everyone. Thanks. Excellent talks. I'm Ali Kaki from Stanford University. Parminder, question for you. You were talking about for building on 1806 and intensifying systemic therapy, and I think in the concept you presented, sort of thinking about it after doing the chemo RT. What about doing it before, like using ctDNA to select for people who have systemic ctDNA positivity just with MIBC, and then intensifying those people with systemic therapy prior to doing chemoradiation? Any thoughts on that idea?
So, Ali, thanks. Great question. Yeah. And I'm going to come back to Kent's question again because I have a question on top of that. So to answer Ali's question, so Ali's asking why not do neoadjuvant strategy in the after 1806 concept. So again, that concept is in build, and we are doing brainstormings, and there will be a session for brainstorming here also on that. And all options are on the table. Now what we thought of as the experiences we are gaining from 1806 will be incorporated into the next trial. And one of the experiences which Scott has contributed a lot of patients, over 60 patients on that trial, is that one patients want to get started with their treatment right away. And then only if we tell them that they are very, very high risk is when they would opt for subsequent therapies. Otherwise, they want to just finish off and leave because they are coming from far off places, coming to these centers. And so thinking of those designs is that, okay, so the definitive therapy is chemo RT, and we have done that. And now if we can identify patients who truly need intensification, maybe those who have some residual disease in the bladder, maybe those who had high-risk features, which we will identify on 1806 because we have stratified those risk factors, T3, T4 versus T2, chemotherapy regimen, node radiation, not radiation. So we will get all that data from 1806, and we can very finely predict events. Are they happening loco-regionally, or they are happening distantly? And then we are collecting blood samples on 1806 to do ctDNA testing. So the next trial will be built on 1806, and our hope is that we'll be able to build a high-risk trial. But if it turned out to be that is a hurdle because we want to keep eligibility open, we could then design a trial where we'll allow all comers who want to opt for the trial, and then do a predefined subgroup analysis in a high-risk patient population later on. So I agree with that, but I think some of the experience from 1806 is guiding us towards a design where patients who are post-therapy and we feel that they're still high risk, that we would encourage them to go on to that trial. So, Scott.
And one of the other potential options in your design is, if you're agnostic to what happens prior to TMT, it will allow docs who say, look, I've got a really bad one, I want to give neoadjuvant chemo because it's a healthy 65-year-old patient. They're going to look at that data and say, I'm going to give neoadjuvant chemo, then I'm going to give TMT. They still can go in your trial as long as we don't exclude them because of prior chemo, neoadjuvant chemo.
Ali, I think another point to make about using CTCs to decide on therapy up front is, and we'll be waiting for the data from 1806 to understand how CTCs sort of exist and work in a TMT population. Remember, these patients have had maximal TUR before they're sort of deciding on therapy. So they might not have many circulating tumor cells. And so we don't even know in the patients who are choosing radiation, what is a threshold? How important is that, in that population that's already had TURBT and no evidence of metastatic disease? So I think that, there's a lot to be learned yet, but that intensifying systemic therapy is really important, and figuring out the exact timing is key.
I need to go back to Kent's question. So a question to you, Brian, on that when you plan adjuvant radiation in a case like this, wouldn't you offer them concurrent chemoradiation And then we are saying then they are getting concurrent chemoradiation and plus nivolumab for a year. Is that how you would propose that design?
So I haven't done a lot of adjuvant concurrent chemo and radiation just because the prospective data was doing the chemo kind of sequentially with the radiation from the Egyptian trial. I mean, I think it's reasonable. I mean, anecdotally, we did it once or twice on like young, very healthy patients where we wanted to be maximally aggressive. I mean, I think it's certainly reasonable. And with, you know, the IMRT toxicities being so low, it's certainly reasonable. You know, I think that's, there just isn't, you know, data for a value of kind of adjuvant chemo RT given concurrently, but look, we can extrapolate from the concurrent chemo RT data from BC 2001. I mean, biologically, it makes sense that there could be, you know, a good sensitization. I think it depends some on just the performance status and baseline GI toxicity of patients we're encountering, you know, and how much is too much, you know, and
I think also it's like really important to distinguish adjuvant versus salvage. If you've got a salvage patient with a local recurrence, chemoradiation makes sense. We at USC did a small retrospective study of our experience with that, and the combination of chemoradiation in a salvage setting is beneficial because you're getting the radiosensitization. In an adjuvant setting where you're treating, you know, just microscopic disease, I think, you know, we don't obviously have data, as Brian's saying, but, you know, possibly in that setting, just the IO plus radiation is enough. Anne? So the question is a two-part question, Brian, which is for, I think, mostly you and I, which is, one, what is a maximal TURBT in the setting of T4 disease? Maybe Scott as well. And then also, you know, use of fiducials, plus, minus, what are they helping with? What are they, you know, doing? I can answer the second question first, and then Brian obviously jump in, or Scott or anyone, or Kent as well. So many people use fiducials to delineate the tumor bed because on SWOG NRG 1806 there is the option for what's called a tumor bed boost. Instead of treating the whole bladder to the whole dose, you treat the whole bladder to less, you know, like a little less dose, and then you complete the radiation dose to just the tumor bed. In that setting, fiducials make a great bit of difference because you can very easily see, obviously, what is hard to see on cross-sectional imaging with a CT. There's not great data as of yet to say that a tumor bed boost actually is beneficial over whole bladder therapy. And when they've looked at subset analysis from BC 2001, they showed that that bladder tumor boost didn't really make a difference, and it also didn't really decrease toxicity. And so then you really do have to say, well, then why would you do it? And so I think that there's many, you know, at least two schools of thought on that. You know, you could point to in that BC 2001 study, they didn't use IMRT, and so they had like larger fields. As a radiation oncologist, we could sit and pick it apart. But regardless, I think that is the role of fiducials. I don't love them personally, but I know a lot of people who like them. I think there's an interesting question of whether or not you should actually be giving more dose, like an integrated boost, a little extra dose to the tumor bed. That's not been looked at. That's something that certainly, you know, is a question to look at. But that's not the way that. Right. I mean, that's exactly it. Because it's not really a tumor. Because like when most people hear tumor boost, they think the tumor's getting more dosed. It's actually really de-escalation to the rest of the bladder, is the way that it's currently done. I don't know if others, I don't want to sort of monopolize. Brian, Scott, do you guys want to talk about the TURBT and T4 disease?
All of our TURBTs are sort of maximal, down to fat, transmural. I call it a transmural radical resection, which many would say Like that would be a perforation, but it's not. It's a transmural resection. In the T4 setting, I think I've only put maybe 2 or 3 patients that have T4 disease, really elderly patients. And I mean, you're just resecting down and you go all the way through the bladder and you see fat in a normal area and then you still see tumor. I don't keep resecting beyond that. I mean, you could, but not a great idea. You'll be leaving the Foley in for a month and they won't like you. So I think it is an interesting question. I've got other slides, is the fact that you can achieve a gross complete TUR, whatever that means, is that prognostic or is it predictive? We don't know. The British are trying to figure that out. They may, but we don't know the answer. But it definitely gives me a sense in consultation with the patient. Number one, what was the total volume? Because I've found in my experience, if I'm resecting half this patient's bladder, even if they had good function beforehand, they're not going to have great function after. So I've made the mistake of being ultra aggressive early on, and I resected some people's transmurally 50% of their bladder. It took me forever to try to get them to get their bladders out for a functional reason, okay? And they got reflux and they had non-compliant bladders, but it was rare. And I've learned, if you very, very high volume, probably go down a surgical pathway. And it gives me a little bit of an idea of prognostication for the patient.
Yeah, I'm happy to weigh in on the fiducial. I mean, I'm kind of similar mind to Leslie on that. We were using Trace It when it was commercially available. It's no longer available. So the urologists that I've worked with, we typically haven't placed fiducials. I do tend to do more of a tumor boost, but again, kind of as Leslie defined it, not higher dose, but really just de-escalating, but only in very select patients where I think I can get away with it. And I'm often defining the volume, getting the full dose very generously. So in a sense, I'm almost just looking for, especially at the dome of the bladder, are there areas more in the dome close to bowel that I'm quite confident don't have gross disease? And then I'll kind of cheat with some of my contours there. So I'm not asking my dosimetrist to treat the entire bladder to full dose without sort of prioritization on where they could cheat a little bit in the interest of reducing toxicity, and then focusing dose where I want it, which is, in the areas more likely to have tumor. I think that the T4 into the prostate is sort of a unique situation. My feeling there is if the surgeons, aren't able to do a big resection of the prostate, that's fine. I'll sometimes dose escalate the prostate. I mean, we can take the prostate to a very high dose if we need to. So I've even gone above, our usual bladder doses for T4 of the prostate, knowing that, radiation can control gross disease in the prostate very well.
I also wanted to just add on that note that some of these patients that we have treated, a lot of them are very older too. And in our smaller study for DUART, we didn't actually see the outcome difference between patients who had maximal TURBT versus those who didn't. So more to come from Parminder's study as whether that shows a difference. But, there is a feasibility issue in these older patients. And a lot of times I've seen even the urologists don't want to kind of do maximal TURBT because they're worried about the tolerance of future treatments if they go. So while it's desirable, I think with the era of immunotherapy, we still need to see how the responses would differ.
Hi, Scott Nealio from NYU. So one, thank you for all of your work you're doing to help patients preserve their bladders. I'm wondering, while we still have to wait for SWOG to finish, read out, and this DERVA trial to finish and read out, what are your thoughts of PD-1 versus PD-L1 at this point? Because we had in the metastatic setting some PD-L1 inhibitors that have been lost their FDA approval with DERVA and Atezo, with negative trials with Atezo 130 and 010. just general thoughts, and what do we do if these trials are negative? Do we look forward to a PD-1 trial? How does that impact new trials we design?
Yeah, thank you so much for that question. It's that's something which we have learned over the years as these molecules were approved in 2015, 16, and then these subsequent trials came out designing. In the early times, there was a sense that maybe they are not different, and the activities across the board for bladder cancer, and so at that time when these trials were being designed, they were agnostic to this idea that there was a difference. It was more idea based on who was ready to collaborate and want to move forward with the trial. So some of that played into the selection of the molecule. But as with time, the field has evolved, and we are seeing that maybe, and it could be, some of us may think that some of that difference, loss of difference, was attributed to just the trial design or the selection of the patient and how patients responded in the standard of care arms, and maybe we lost the benefit because the true benefit was very limited, 10-15% benefit with IO alone in metastatic disease. And so, but yes, now where we are is that PD-L1s have lost the ground to PD-1s, and so that's why at this point the next trial we put Pembro in the treatment arm, thinking that maybe when this trial will come on, Pembro will be there as one of the approved agents and will be part of the combination. And then we also know there is a contemporary trial to S1806 which is run by Merck looking at Pembro in chemo-RT space, and so it will kind of lay the field out. So we will not lose time in the sense that trial is also running and S1806 is running at the same time. And so as data will come out from both these trials, we'll have a sense of where the activity is. Now, the question is, which has not been investigated previously, is the combination of PD-L1 in conjunction with radiation. And so we can still say there is hope in the sense that because this is a novel strategy which has not been tested in the previous trials which have shown less activity of PD-L1, is this combination of PD-L1 with radiation may play out in the favor, and it may turn out to be positive. And so that's why the EPIC trial, which is the next trial, will have standard of care treatment, as Scott alluded to, going into that adjuvant phase. That whatever the standard of care would be at that time, if patients have received chemoradiation with a definitive intent, with whatever combination, they can then get this additional therapy based on their high-risk features, and get this intensification of combining ADCCs with Pembro, and then move forward with the next design. And so yes, we are considering what you're saying, the now lack of efficacy of PD-L1 in advanced setting, but at the same time, these radiation trials will read out in next times, and we'll find out how atezo with radiation lines up with atezo with chemo or atezo alone in advanced disease settings. So thanks for that question.
I actually have one question for the surgeons in the room, so to engage all of you. Oh, did you want to make
can I just add something? I think comparison of PD-1 versus PD-L1, I think it's still very premature to say. It's $1 million question, and we all know avelumab worked in advanced settings, so I think we shouldn't forget that the PD-L1s have advantage. So more to come on that, but I don't think so. We are in a position to say which one is better, but of course some of the reads for the PD-1s are coming better. But again, avelumab is approved. So.
Okay, so I think, everyone in this room probably agrees that, chemoradiation, TMT, is equivalent to cystectomy in the properly selected patient, but says a radiation oncologist. But what I want to know is, Scott presented data on RTOG 0926, a trial looking at chemoradiotherapy in the non-muscle invasive space in patients who were intended for their next step to be cystectomy. That was a very important enrollment or eligibility criteria. It wasn't just that they had BCG unresponsive disease. It had to be that their next step was to go to cystectomy. How far are we away from that being something that is widely accepted, where in non-muscle invasive disease, you have a patient who is supposed to, has BCG unresponsive, has gone through other lines of therapies. Next step is cystectomy. No, we're going to give them chemoradiation. Scott, do you want to start? Anne, other surgeons? These are just two I know.
I personally think that in the T1 setting, there's a role in a trial. So T1 with LVI, or just T1, recommending a first cystectomy, I'm happy to offer that patient a trial. I think outside of the T1 space, it becomes a little bit more problematic, and there's challenges regardless of accruing patients in this space. I mean, the ADAPT bladder trial, amazing trial, if anybody in here is on that trial. But the list of authors was longer than the number of patients in the trial. It was a phase 1, it came out of a CTPM from the NCI. A lot of effort went into that trial, but there were more authors than there were patients. It is an extraordinarily difficult space, and we'd have to sort of get buy-in across the board. I think the buy-in would have to be on that T1 population. Any other surgeons that are in want to comment?
While they're commenting, can I add something to the surgeons? So once they do get like focal radiation, is it really hard to resect the bladder? Can you share that as well? Because can patients go through that and then undergo radical cystectomy, or it's an absolute no?
No. There's data. There's data out of Boston on salvage cystectomy. Thankfully, we put a lot of patients on chemorads. I've only had to do a couple of salvage cystectomies. But for the potential loss in functional ability to have a continent orthotopic neobladder, which is not always there, okay? But typically these patients are, at least in my world, they're out of the age range for that anyway, okay? I'm sort of community doc with an academic title.
I'm going to fight you on that because we have data.
I know you do. I know you do. But I know it's there. So it is. But majority of these patients in my practice, they're going to get a conduit regardless because of their age range. I don't find that the salvage cystectomies have been that much different. They're all done open or robotic, however you do them. Complication rates are high regardless of how you do them. It's a nasty surgery. It's a nasty recovery for the patient. It's a fun surgery for the surgeons. Does
anyone else want to comment on the T1 issue?
Actually, I just wanted to hear from the patients, actually, if we have any, about this question. In my experience, and I'm not a surgeon or a radiation oncologist, but when I've talked to patients about this issue, what it always comes down to is, will I have a chance to remove my bladder later? Or if I go down the chemo RT route, have I sentenced myself to having this bladder and potential distant metastases associated with it? And so great. Well, I'd love to hear from the patients about thinking through that idea of having maybe an increased risk of a surgical option after radiation, especially in the T1 space. So if there's anybody.
I do want to address it real quick. I just want to say one thing. Unlike prostate, if you're a prostate cancer patient and you walk into any of the tertiary centers in the U.S., you most likely are going to get great quality care because you're going to see a radiation oncologist and a surgeon, and maybe a medical oncologist. If you're a bladder cancer patient, you don't have multidisciplinary care at 95% of the places, even the tertiary or quaternary care centers that are on the billboards. And I think that's something that needs to change because we all bring our own inherent biases. How many times does a prostate cancer patient show up to me who's 68, he's got Gleason 7 disease, and somebody's told him, well, if I have radiation, I can't have a prostatectomy. Like, well, that's not true. We do salvage prostates all the time, or we can do ablation. There are other options. But just because your urologist doesn't do it or he's got that preconceived bias, we have to sort of eliminate those things and really present this data to the patients fairly. And I don't think the urologic community has done a good job of doing this in the U.S. And we have to, on the other side, radiation oncologists love to radiate, okay? So there's a balance, and maybe the medical oncologist is the arbitrator here. So.
So this is something, when I talk to patients, I always tell them they need to ask the question. I think there is relevance to what is my current status, my age, my physical condition. I think those are factors, and I think it's going to be a very individual decision. I think for many people, the risk of recurrence is like high on the list, if you remember the slide that Arminder presented. So I think we always have to keep this in mind front and center.
Armin Smith, surgeon. So I think I can address, I have a question. I think we can address some things too. I think this is such an exciting space, the bladder preservation. And I think we have more questions than answers right now. And it's just really exciting that everybody's moving in this direction and there's enthusiasm about it. So starting with the MDC question, we've tried, and we have a lot of this MDC discussions at Hopkins among us, but it's kind of hard to bring patients in a time-sensitive manner to MDC for bladder, and I think that's been kind of the stopgap for a lot of it. Because for the prostate MDCs, there's never emergency to get a patient in to get everything done, or occasionally there is. But for bladder, we try to get them in as soon as possible. And I think bringing things in a timely fashion is usually the constraint. But I agree. I think, if you have multiple people in place, the discussion is much better and the options are wider for the patient. When I offer patients chemo or TMT, I always kind of start by telling them, there's studies that show that the results are just as good. We don't know who's the best candidate for it. And, unfortunately, I think you might be limited in the urinary diversion options afterwards. And that's kind of the conversation that happens, and a lot of people, pick based on their preferences. So I think, more urologists should be offering it, I agree, and I think as this data becomes more mainstream, and that will happen eventually. As far as the T1 disease, I think it's going to be hard to accrue in this setting because it's kind of hard to put a patient who does not have a worsening of disease, so it's a TA or CIS patient to offer them, chemoradiation, because I don't think we know if this is going to work for CIS patients, right? The thinking is we won't. Yeah. So for T1 and I think variant histologies, we might have a better success recruiting patients for that. Now the question I had for the group is, and what caught my attention is when you said the maximum TRBT may not be offering as much of a benefit as we think. Now, do you think our treatments are becoming as good as we don't need to eradicate the disease? So when we put patients on bladder preservation, before our goal was to eradicate as much as possible a visible disease and get them through. Now, do we have our treatments to the point that we can just get a sample, just maybe debulk the tumor and send the patient? And if not, then we should be utilizing more maybe partial cystectomy than maximum TRBT for smaller tumors. So just some thoughts more than anything else.
I think that's a good point. I think it's a very big may right now. So we will need to know if maximum TURBT does, but the initial appearance may be that perhaps there are more cancer cells and maybe they are improving the immune response. Just a thought. I think it has been floated, and there is some literature around it. Don't know if that would be, but you're right. As we improve our systemic therapies, maybe that may not be the crucial barrier.
Yeah, my personal bias is that yes, a maximal debulking TURBT, adds value. There's a lot of U.S. data, suggesting that. I think, some folks on the panel brought up, well, is it predictive, is it prognostic? I don't know the answer, but if we just extrapolate from other diseases as well as from the bulk of the bladder cancer literature, I mean, there's very strong data in breast cancer, which, I mean, bladder preservation is essentially just mimicking, what happened with the breast conservation studies of the 1980s. We're just decades behind breast cancer. But there, like, the high quality lumpectomy was hugely important for the success of that approach. And, I firmly believe that the TURBT is at least as important, maybe more so than anything I'm doing with the radiation. In the same way that, breast cancer, lumpectomy, radiation is still a surgically treated disease. This is a surgically treated disease. And good surgery by skilled urologists is absolutely critical.
To kind of also comment on the high-grade T1 question, Adam Gudzinski, I'm a urologist at Beaumont Hospital, work at a group kind of like Dr. Delacroix, out in the community, but getting a lot of interesting things that come through our doors. What I found is I remember explaining to a patient once had high-grade T1 recurrence. I go, well, I think we should take your bladder out at this point, because and they're like, well, I just want to keep it. I was like, well, if it was in the muscle, then I'd be telling you we could do chemo and rads, and realizing that this is just as an odd explanation. Oh, if only your cancer would worse, then you could keep your bladder. And so I think there is that space for a high-grade T1. Just, explaining that to someone or trying to rationalize my recommendation against guidelines, and realizing that from actually a rational person's standpoint, it sounds crazy. But I think that is a place that if you're probably going to start somewhere with chemo rads for primary non-muscle invasive, maybe even in the recurrent setting. But I know that's what that original trial was for, and they accrued, 37 patients over a decade? Pretty small place.
I mean, we're hoping with the follow-up trial, and again, it's really going to be dependent on urologists like those in the room and medical oncologists as well, that, because of that data and because of important data that Leslie and the folks at MGH have published, a new paper that's coming out in the Red Journal, that there's more and more data now that chemo-RT can achieve outcomes comparable to cystectomy. And, now that we're doing it more on the SWOG trial, why not try it in recurrent high-grade T1? So, we're excited to try to bring this trial forward, and hopefully we can get it approved, and look forward to your support, to those of you interested in opening it if this comes to fruition.
So the way the discussion has turned really gets to my question. So I'm Suzanne Cole. I work at UT Southwestern, which is like a dominant urology-centric place. And so at the beginning, when Parminder was talking about how he kind of shopped his idea around to all of the cooperative groups, I'm really curious, and Monika, you can talk to this too, about how did you guys get buy-in? Because I've been in SWOG with you, where everybody just tears everything apart, especially the surgeons who dominate everything and are super against radiation, which was not done at our institution, not done. I don't think anybody had chemoradiation ever, until your trial came out and we opened your trial and then people started doing it. And so I'm curious, how did you get buy-in? Because, the task force, there's so many opinions.
So again, very important question, Suzanne, and that's where this Seth always taught me this, that it always takes a village, and so from the very beginning I started working on putting this group together, and we knew from the beginning, and it was not only surgeons but also medical oncologists which balked at the idea, oh, this trial will not accrue. This was in the GU 2016 when I was presenting, and senior folks, even med-oncs, were saying this is not going to accrue. There were many things which I did. One was to kind of reach out to each cooperative group, engage with NCORP, figured out which centers are accruing well on 1605, because that's again a bladder preservation idea, even though it is a non-muscle invasive space. Reach out to patient advocates to put this on the, from patients' perspective, we need to push this idea that patients are asking, and you can see all those things. So we did surveys We reached out to all surgeons in SWOG committee. If we open this trial, what do you think? How many patients? Can you put 1 patient a month? Can you put 2 patients a month? And we kind of added those data in. And my estimate, even before the trial was open, was that we could accrue 8 patients a month if at least these folks can pitch in their patients. So I have a sense, okay, 8 patients. So we proposed our design based on that. And we are now hitting close to 9. And so each peg in this wheel contributed it to move forward. It was not just the surgeons, it was everybody. And as Scott said, patients starts asking for it, that, oh, there's a bladder preservation idea, so we want to do it. Even if Scott would say there is a maybe slightly higher or slightly less in the beginning that the outcomes could be compromised, but still patients wanted it. And so I think it is a multi-prong approach. You reach out to everyone, you slowly buy in, patients are asking, cooperative groups, NCORP sites. So all that put together is able to move this thing forward. It was not just one element.
The ship is turning. I mean, look, who would have thought 1806 would have accrued this many patients in this time frame? It's changing. But the urologists in the room, I'm the oldest one in here probably. Okay? Yeah, I'm the oldest one in here. So I think it's gonna be it's the next generation of urologists too who are very engaged, and this bias held strong. I mean, I remember being a couple years out as a faculty. I sent the patient to a psychiatrist who wanted chemorads. I'm serious. I mean, it's not a joke. It's serious. That's how ingrained it is at many places in this country.
And then that's why for this, like the purpose of this panel, you notice that Brian and I are the only radiation oncologists. We intentionally wanted to like make this a discussion that's multi-specialty because it really is a multi-specialty discussion, and you need engagement from everyone to make this happen. And I also feel your pain, having been a radiation oncologist at USC for 9 years before switching to Cedars-Sinai. I tried to get bladder preservation on so many patients, and it just took perseverance.
And just to add to Suzanne's question, and everybody on the panel, I think this is so correct. Like all hands need to be on the deck for the bladder preservation. We all like it or not, I think the gatekeepers of the bladder cancer are urologists, and that's their first contact. So I think if they're not hearing this, they're probably not going to hear anything you say after that. And I've seen it personally; it's true in some, but I think we're making some changes. And speaking to the cooperative groups is very important. I know EA 8185 is not doing so well as 1806. It also hit in the time of COVID, where people did want to open rare tumor because they wanted to preserve their resources for the most common, cancer types of the trials. So I think little rationing also didn't do very well. But I think having a multidisciplinary meeting is so important. And I think somebody in the room mentioned it. That's different than the process, and it's so true. When these patients come, I think we need to channel them as fast as we can.
Just a quick comment. I think I agree with Scott. I mean, I think that the sort of tide has shifted so much. I haven't seen a bladder cancer patient in the last 2 months who doesn't say, who's doing any research at all, who doesn't say, I read I can keep my bladder now, And so it's a totally different conversation, which is, obviously just going to continue to push the field forward. And I do think it's going to still be a pretty tough sell in the non-muscle invasive space. I think particularly with some of there's so many novel intravesical and salvage intravesical treatments and pretzels and blah, 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 that I think that there's perceived, we don't know yet, less toxicity with those treatments than with radiation in a non-muscle invasive space. And despite being part of the paper showing that urinary diversion is not affected by radiation, I think that that's pretty selected. And I also think that there are really probably a lot of gender differences in that we certainly have not looked at. And I think in female patients, to me, no question, doing a neobladder after radiation is still like something I would not offer personally in terms.
So we've made so much progress, but we are changing a culture. So one of the things, I want to go back to Suzanne's comment, one of the things that I think needs to be really considered is how we frame things in the guidelines. Okay, if you frame the question, does the patient qualify for radical cystectomy, that's the wrong framing, okay? Because that means radical cystectomy is king, all right? And as we change going forward, the guidelines have got to come along with us. And they've got to talk about whether or not bladder preservation makes sense, not whether radical cystectomy is the first choice.
Well, we're a little over, and I think that it's always great to end on a patient's voice. So thank you everyone for coming. Thank you for engaging with us on this topic.